Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. I would like to welcome you all on behalf of the Emirates Diabetes Endocrine Society Board for tonight's webinar, which is going to cover the redefining metabolic disease, obesity, and MASH. The webinar is CME accredited, and it is supported by Boehringer Ingraham, and we thank them for their generous support. There are a few housekeeping that I would like just to share with you. The webinar is a live stream on EDS YouTube channel, and the webinar will be available on demand at the EDS Institute website on www.edsinstitute.org. And as I mentioned, is CME accredited, and you will be receiving the points once you fill the survey that will be sent to your register email. We will shortly, I will be, introducing the two speakers for today's webinar, and we will leave the Q&A at the end of the two talks. So if you have any question, please just, type them in the chat box and mention the speaker name. So my name Fathi Al-Awadi. I'm a consultant endocrinologist and head of endocrine department at Dubai Health, and a president of Emirates Diabetes Endocrine Society. Our first talk will be about the obesity, MASH, at the metabolic crossroad, which is the burden and the guideline update. And it gives me a great pleasure and honor to introduce my long-term colleague, Dr. Khadija Hafez, who's a consultant physician in internal medicine and head of diabetes unit at Rashid Hospital, Dubai Academic Health Corporate. Her work focused mainly on diabetes, obesity, metabolic disorder at Rashid Hospital. She's a fellow of Royal College of Physicians of Edinburgh with an over 2 decades of a clinical experience. She's also a clinical professor at Mohammed bin Rashid University of Medicine and Health Science, the MBRU, and she's a member of UAE National Diabetes Guidelines Steering Committee and the editorial board member of Dubai Diabetes Endocrine Journal. Dr. Khadija is heavily involved in research, and her research interests include cardiometabolic complication of diabetes and obesity with multiple regional and international publication. Dr. Khadija, the floor is yours. Please unmute yourself, share your presentation in a slide mode.
Assalamu alaikum, dear colleagues. Thank you so much for the very generous introduction. It gives me a great pleasure to be part of this webinar to discuss a really important topic. Let me just share my slides and put that on presentation mode. So let's start here. Right, so as I said, I'm really delighted to be part of the webinar, and I'd like to thank our chairperson and the organizers for inviting me to give this really important talk on the metabolic problems associated with obesity, and we're going to concentrate on MASH. So before I do that, here are my disclosures. And I think the audience is very well aware that obesity is indeed a major global health challenge. And judging from the projections, it looks like it's going to be a problem for many years to come. So we estimate that currently there's 1 billion people worldwide that are living with obesity. And then if we look at the projections for 2035 in almost all the continents, they are in the northern trajectory. Now, we here in the Middle East as well are not spared from this statistics. And these are figures that were derived from our colleagues from Dubai Hospital. They published this last year. And as you can see, 63.4% of both obesity and overweight individuals in our region. So this is a huge problem. So what is obesity? Now, this is a condition that we previously just defined by one single anthropometric measurement. But we now understand that it is indeed a complex chronic disease in which the abnormal excess body fat results in health problems. It increases the risk for long-term medical complication, and it does reduce the individual's lifespan as well. And this has been agreed upon by many organizations and societies. And indeed, we know that we all agree that it's a chronic disease that will require sustained intervention. Now, at the heart of obesity is this dysregulation of energy. Yes, it's complex, it's progressive, it's relapsing, but it's the energy dysregulation that, we all need to contend with. And in fact, this obesity map just shows how complex this is. There's a complex interplay of both neuronal, hormonal, and metabolic pathways. And understanding this, then takes away the onus on the patient, and it's not just about eat less and move more. And indeed, obesity is associated with a lot of metabolic and biochemical complications from the head to the toe. We have clinical conditions that we all see in our clinical practice, and we all struggle with our patients. Now, the CKM over the last 5 years has gained a lot of attention, but now we are understanding as well that the liver is not a silent bystander, and therefore we need to have a little closer look onto what goes on into the liver as well. Now, these metabolic complications are, of course, associated with a reduction in the quality of life, and there is a considerable cost related to looking after the complications of obesity. And as you can see from the curves, that the relationship is linear and exponential. As the BMI increases, the healthcare costs also increase exponentially. So what do the guidelines say about the diagnosis and management of obesity? And there are quite a number of guidelines which have a few subtle differences between them, and I'll highlight those in the coming slides. So in the beginning, we relied heavily on the BMI as a screening tool, and I'm sure you're all aware of how to do that. And then what's important is really to think about the staging, and you can either use the American Association of Clinical Endocrinologists staging, 3-stage process of classifying obesity. But I think the Canadians probably had a much more nuanced staging process where they focused on both the metabolic, the psychological, and the physical impact of obesity on a patient's health. So what about this BMI? And, we've come to understand, of course, that it has a number of flaws. It may not correspond to the same degree of fat mass in different individuals. And we know that in bodybuilders who are much more muscular, the BMI then is a false indicator of the fat mass. And then there's a variation in the distribution of the fat. So if you're carrying your fat more centrally, the BMI is not going to be a very good reflection of that. And at the same BMI level, women tend to have more body fat than men do. And then people of Asian ethnicity also tend to have higher fat percentages than people of non-Asian background. And older adults often have a higher body fat than younger adults as well. And therefore, it isn't enough just to use the BMI. Other anthropometric measurements, such as the waist circumference and the waist-hip ratio, should also be used in. And of course, there are different cutoff points depending on the individual's ethnicities. And the reason for that as well correlates very well with the cardiometabolic risk. So we know that anthropometric measurements which look at central obesity, so waist circumference, waist-to-hip ratio, actually are better predictors of all-cause mortality and of cardiovascular mortality as well, whereas the BMI just shows a J-shaped relationship with mortality. Last year, early last year in January, the Lancet Commission proposed a new approach in the clinical assessment and management of obesity, and I'll quickly go through that. So again, you know, the BMI is not out of the window. You still use that as a screening tool, but you add that on with the other anthropometric measurements that I just mentioned, or you can do direct body fat measurements. That is then going to be followed by a comprehensive medical history and physical examination to look for signs and symptoms of organ dysfunction. If there are no signs or symptoms or any limitations in the daily activities, then we can say that this person has preclinical obesity, and the focus then becomes on reduction of risks, factors, and prevention of progression into clinical obesity. So clinical obesity is a state whereby you have already signs or symptoms of organ dysfunction that are limiting this individual's daily activity. And the focus then is, of course, to use evidence-based, individualized treatments that would delay the progression of the complications and improve the quality of life. In the same year, so that's last year, in the summer, the European Association on the Study of Diabetes also published their framework for the diagnosis and staging of obesity in adults, and it was more or less similar to what the Lancet Commission were proposing. Again, we need to look at those anthropometric measurements together with the clinical components, which highlight the medical, the functional, and the mental domain. And then we need to use the personalized therapeutic targets for our patients. And if those are not working, we intensify therapy so that we can reach those personalized therapeutic targets. Now, you're all aware of the sort of clinical conditions that are associated with obesity and the reduction in function because of the excess adiposity. So what I'm going to do, and because the focus for this webinar is to really look at what is happening in the liver, I'm going to concentrate on what is it that's happening with the metabolic complications of obesity within the liver. First of all, if we look at the epidemiology, it is by far the commonest. You know, it's something that we have, you know, sort of been having a blind eye to. We've concentrated a lot on the cardiovascular and renal complications, but as you can see there, MASLD really accounts for about 75% of individuals with obesity, and 34% of them have MASH. And there's a very close overlap between the cardio and renal complications. So what MASLD really encompasses is this. It includes both metabolic dysfunction-associated liver disease and metabolic dysfunction-associated steatohepatitis of MASH. And the difference there is just in the fibrosis. So in MASL, you have accumulation of fat in the liver with or without mild inflammation, whereas when you have MASH, you have evidence of inflammation, and there's already hepatocyte damage, which then leads to fibrosis, may lead to cirrhosis, and of course, decompensated liver disease, and that also is a precursor sometimes and a risk factor for development of hepatocellular carcinoma. So the liver, as we said, is not a silent bystander. It's an important organ. We all know that it is involved in bilirubin and metabolism and in the storage and metabolism of the fat-soluble vitamins. It's important for drug and toxin metabolism, and it is essential in fat and cholesterol metabolism and nutrient metabolism as well. And the hormone that, you know, is really crucial and a big player within this context is indeed glucagon, produced by the alpha cells within the pancreas. And when everything is normal, we have a good milieu of both lipid, glucose, and amino acid metabolism. On the other hand, when there's glucagon dysfunction, it impairs both hepatic lipid and amino acid metabolism, leading to increased lipogenesis. So you have increased spillover of fat, increase in glycogenolysis and gluconeogenesis, and it upsets the amino acid metabolism as well. So what happens is you've now got an elevated glucagon-alanine index, which is actually well demonstrated in these physiological studies where you see the plasma glucagon levels are quite high in even these individuals with normal glucose tolerance, but already have evidence of MASLD. Likewise, in individuals with type 2 diabetes with MASLD. And then when you look at the plasma amino acid levels as well, again, in those individuals with MASLD and type 2 diabetes, they have higher levels than when you have either normal glucose tolerance or type 2 diabetes without the presence of metabolic dysfunction-associated liver disease. So if the problem was just concentrated in the liver, you would say, all right, maybe it's containable and we can manage it. But unfortunately, it is not just concentrated on the liver, because the excess liver fat and the excess visceral fat, as we know, spills over, and it is a precursor for metabolic dysfunction, either new onset or deterioration of existing metabolic conditions, and is associated with an increased risk for cardiovascular disease and mortality. And we know that the higher the content of the liver fat, the higher it is the likelihood of succumbing to these cardiovascular events. So here shown quite clearly that the severity of the liver fat predicts also future cardiovascular events. So it's important then that we can look for strategies that would reduce both liver and visceral fat accumulation, because we know that when we do that, we lower cardiovascular risk and improve metabolic health. And if we reduce the liver fat, it does, again, improve both the lipid and glycemic status, as well as markers of liver injury and fibrosis. And in order to do that, of course, is first we need to identify how do we look for metabolic dysfunction-associated liver disease. The algorithm is shown here, and it's very simple. We use non-invasive tests. And there's good harmony between the European side and then the American side. Subtle differences, again, in the tests that can be used. But by and large, the first step is really in all patients with type 2 diabetes or obesity with more than one cardiometabolic risk factor, or they've got persistently elevated liver enzyme, we can use the FIB-4 score, which is very easy. It's incorporated into some of our electronic healthcare records. And the thing to look at is the score. If it's less than 1.3, then we need to assess every 1 to 3 years. If, however, it's in the intermediate stage, then we need to intensify the management of the comorbidities and then reassess, or we can even go ahead and do some more tests like the VCTE, or as in the American algorithm, they use either the ELF or transient elastography. And if the levels are high, or if your FIB score at the outset was greater than 2.67, then that becomes a criteria for referral to specialized hepatology services and intensification of the comorbidities in a multidisciplinary team. The other side of the Atlantic, the Americans, saying almost the same thing. The figures are exactly the same, but they're just using ELF instead of the VCTE. So early diagnosis of obesity is really important, because that we know can lead to improvements in weight and therefore the clinical outcomes, and the amount of weight loss that is required to make an impact on steatohepatitis is in the order of about 10 to 15%. Unfortunately, weight loss alone is insufficient to reverse advanced fibrosis. So at a level where you have just MASL, you can reduce the amount of liver fat, but once you've got fibrosis, then weight loss alone becomes insufficient. So the goals of obesity treatment are really, first and foremost, look at primary prevention. We cannot ignore that. And then to think about this concept that the Lancet Commission came up with, preclinical obesity, in which we try to reduce the risk factors, and then think about, when you have clinical obesity, how do we improve the clinical outcomes and prevent organ damage? And this has to be sustained because, as you know, the body has evolved to maintain a certain body fat mass that is, very tightly regulated through this feedback control system that adjusts the energy intake and energy expenditure. And so you have sort of like a tug of war where as soon as, you've reduced your calories, maybe increase your activities, you have on the other side all these hormonal adaptations that take place that, want to sabotage the reduction in weight. And so we need to be thinking about obesity management as a chronic condition like we do with diabetes and hypertension, because we know that if you stop the intervention, then the disease comes back. And this has been demonstrated whether you're using lifestyle interventions, as in the Look Ahead study, or whether you're using anti-obesity medications. The other paradigm shift that we've had is to move away from stepped care to more longitudinal care. And so the psychological sort of behavioral interventions, pharmacological interventions, and even bariatric interventions can occur simultaneously rather than having it in a sort of stepwise manner. This slide is a little bit busy, but it just demonstrates, that we use obesity medications depending on the patient's phenotype. But a more pragmatic approach is to use the 5 C's, and that relates to first the contraindications and assess the patient's medical history and see the risk-benefit profile of each of the agents. Look at comorbidities, so use an agent that can not just address the weight, but also the comorbidities. Consider the patient's self-prescribed appetite control symptoms. What sort of administration do they prefer, injectable versus oral? Combinations of treatment, as we said, it's longitudinal lifestyle interventions with anti-obesity agents and surgery in combination. And then, of course, considering the cost and access to these interventions is also very important. So my take-home message is just to reiterate that obesity is indeed a complex, chronic, heterogeneous disease of energy dysregulation. It is a major health challenge that affects over 1 billion people worldwide. It is associated with many overlapping related complications, including MASH, and 75% of people with obesity have metabolic dysfunction-associated liver disease. And new treatment options are now available that may be able to address some of the different elements that are involved in this dysregulation of the body's energy balance, which are going to be discussed by our next eminent speaker. So I will stop sharing. Thank you all for your attention, and hand over back to our chair. Thank you all.
Thank you very much, Dr. Khadija, for the excellent presentation as usual. And as I just mentioned, that we are going to take the Q&A after the second talk. Our second talk will be on mechanistic powerhouse on the GCGR and GLP pathway, redefining the treatment potential, and the Suvaditide spotlight. And it gives me a great honor and pleasure to introduce our speaker, Dr. Miraz, who's a professor of endocrinology at Leicester University with a clinical and research work focused exclusively on obesity and type 2 diabetes. Over 14 years of experience contributed to clinical management, policy, and research of obesity. His research interests focus on the mechanism of action of obesity intervention, including pharmacotherapy, medical devices, and obesity surgery. He's a member of the NICE Obesity Management Guideline Committee and a trustee of Associated of the Study of Obesity, and he is also a chair of research subcommittees of the National Bariatric Surgery Registry, and associate editor of the Journal of Obesity and Surgery for Obesity and Related Disease. Dr. Miraz, the floor is yours. Please share your presentation and use the slide mode.
You can see my slides?
Yes, we can.
Excellent. Well, thank you very much for the invitation and the very kind introduction. What I will be doing is talking a bit more now about how we can use glucagon therapeutically in combination with GLP-1 through this molecule called survodutide. And I think people will be interested to see this data, relatively new data, because it's something very novel. We have been talking over the years about GLP-1, more recently about GIP, and now glucagon is coming into the forefront. So we'll explore that physiology and pharmacology. These are my disclosures. So I will not spend much time talking about GLP-1 that we've known for therapeutically, at least for about 20 years. We know that GLP-1 activation increases insulin secretion from the pancreas, which is good for diabetes. It also works in the brain to reduce hunger, and that causes weight loss, and that improves insulin sensitivity, and in consequence, that improves fatty liver disease through weight loss directly. There are no direct effects of the hormone on the liver. Glucagon is, I suppose, from the endocrine perspective, a bit of a misunderstood hormone. We always consider glucagon to be the bad guy because it increases blood glucose circulation, which is what we did not want. But at very specific concentrations, glucagon can have some very beautiful physiological effects. Number one, it helps lipolysis in adipose tissue, which is indirect and independent of weight loss, and it does exactly the same thing in the liver. It effectively removes fat from the liver, and you can imagine that that can be beneficial for metabolic associated steatohepatitis that we will be talking in more detail in a sec. What glucagon also does through these processes, but also through other mechanisms around the body, is that it increases energy expenditure. So it makes a lot of sense, at least for the treatment of obesity, to combine an agent that reduces food intake with an agent that increases energy expenditure. And this is what has happened with survodutide. And here is the molecule. I wouldn't worry too much about the modifications. These are very smart modifications that have been made on this peptide, which allow it to be a single molecule. But instead of activating just one receptor, it activates two, both the GLP-1 and the glucagon receptor. But it's made in such a way so its activity is much higher, eightfold higher for the GLP-1 than the glucagon receptor, and that has been very carefully designed to reduce side effects and improve efficacy. So what we will do now is we will go through a lot of phase 2 data and have a look at the results and see where they lead us in terms of phase 3 studies. Let's start with this study, which was the use of survodutide in people who have obesity, overweight, and type 2 diabetes. So in this study, about 400 people took part. Their BMI was over 25. And you will see that a number of different survodutide doses were used, some of them once a week, a couple were twice a week. Again, this is part of the dose finding process of a phase 2 study. And the nice thing is that there was also a direct comparison with semaglutide at 1 milligram, i.e. Ozempic. Again, this is phase 2, and therefore the duration of the study is relatively short, about 17 weeks. And it is really important these days to pay attention to how long these studies are, because that makes a really big difference with regards to the outcomes in order for us to be combining like with like. The primary outcome, as you will be expecting, is a reduction in HbA1c, but in addition to that, there were secondary outcomes that included body weight loss and HbA1c targets. So these are the results, quite a few lines. I'll take you through some of the most important ones. Don't worry too much about all of them. This is the effect of the placebo. So we're seeing a reduction in HbA1c with placebo of about 0.3 or so. However, these are the different doses in color of survodutide. Before we go to survodutide, have a look at semaglutide in blue. You follow the line here, and within 17 weeks, there has been a reduction of about 1.5 percentage points in SPA1C, which is already a pretty good result in a very short period of time. And we know that that is what semaglutide does, which is a very good drug. However, what you will notice is that the combination of activation of glucagon and GLP-1 at the highest dose of survodutide, here at 1.8 twice a week, causes a reduction in SpA1C of 1.8, even within the short frame of 17 weeks. So if you follow this part of the slide here, you'll basically see a dose response curve in terms of SpA1C reduction that at some point it reaches a plateau beyond a certain dose. Now, why this is important, it is because, again, we have always been worried about the effect of glucagon activation on glucose regulation. But here what we're seeing is that the effects of GLP-1 on insulin secretion, but also the effects of weight loss during this period seem to be overcoming and overcompensating, in fact, for any potential increases in glucose because of glucagon activation. So this is all very reassuring and, in fact, very encouraging. Let's move on now to obesity without diabetes. This study is much more representative of what we're going to see in the phase 3 studies and in terms of probably licensing, hopefully, of the medication over the next year or two. Here we've got a population which is typical in terms of obesity, so adults with a BMI of over 27 without diabetes, about 400 people, and they were randomized to once a week survodutide at a low dose, 0.6, then 2.4, 3.6, and 4.8 milligrams, and placebo. The study was longer here. They carried on for about 46 weeks, and therefore it is much more comparable to the molecules that we're already using for the treatment of obesity, like semaglutide and tirzepatide. And of course, this aim was to investigate the safety and efficacy. The primary endpoint, unsurprisingly, was percentage weight loss, in addition to other useful secondary endpoints. Here are the results. The placebo weight loss, as expected in most of these RCTs, was 2.3%. And if you follow those lines and you go to the highest dose of survodutide, which was 4.8 milligrams, you will notice that, number one, people have achieved a weight loss of about 19% within 46 weeks of treatment. And you will notice that the graph here has not plateaued yet. You can see the trajectory, which suggests that the weight loss will carry on. So this makes, in terms of obesity, the molecule very competitive to what is already available in clinical use. And hopefully, what we're going to see in the phase 3 studies that are longer, we will touch upon them in a sec, is the full effect of survodutide over the course of 72 weeks, which we expect to be quite substantial. These are the categorical weight losses that we always present in obesity studies: more than 5, more than 10, more than 15, and more than 20% weight loss. And what you'll see is that through the use of survodutide, approximately 40% of patients that were taking the 2 highest doses achieved a weight loss of more than 20%, 4 out of 10 people. And you will remember that the 20% weight loss and above is something that typically a sleeve gastrectomy operation would be able to achieve. There have been nice reductions in waist circumference, so people not only lose subcutaneous fat, but they also lose abdominal fat, which we know is deleterious for the cardiometabolic system. And with the highest dose, a reduction of 16.6 centimeters in waist circumference, starting from about 113 centimeters or so at baseline. As with other GLP-1 based treatments that are causing weight loss, we see that translate into quite substantial reductions in blood pressure, which would be similar to what an antihypertensive would achieve. Remember, these people did not start with a very high blood pressure. They were started at about 125 millimeters or so of systolic. Yet with the highest two doses, the reduction in blood pressure was 9 millimeters of mercury, and in diastolic about 4.5 or so millimeters of mercury, despite normalist blood pressure to start with. And again, together with the effects of dual agonism on weight loss and also on adipose tissue homeostasis as well, we're seeing a reduction of about 27% in triglycerides, which is meaningful, an improvement, a small improvement, which does seem to fluctuate quite a bit actually in HDL. So a little bit of a lack of clarity here as what the molecules are trying to tell us in terms of change. Again, remember that in phase 2 studies, you might see some statistical anomalies because of the small number of participants included, nice reduction in VLDL. So I would say typical improvements in lipid parameters, as we would expect from the magnitude of weight loss. We will see clearer signs in the phase 3 studies. Here are the proportion of people that had pre-diabetes at baseline, 30% of people in the study, and you will see that here we've got in the placebo group. Okay, let me go through this slide again. About 30% of people in both groups had pre-diabetes at baseline, and you'll see how this is switched nicely with survodutide, so that at week 46, 21% of people had pre-diabetes and 78.5% had normal glycemia, so reversal of pre-diabetes in a significant proportion of people. Let's talk about side effects. They are very important. There is nothing there which seems to be new. So typical GLP-1 type of side effects: nausea, vomiting, diarrhea, constipation. The more important number is this one, the percentage of people that discontinue the medication because of side effects. And here, depending on the dose, we're looking at about 20 to 28% discontinuation rate. Again, don't be surprised by these results in phase 2 studies. The discontinuation rates, because of the smaller number of participants, always seems high, and this is a lot lower in the phase 3 studies. So I don't think we're seeing here anything which is unusual, and hopefully we will get even more reassurance by the phase 3 studies. So we talked about obesity, we've talked about type 2 diabetes and the encouraging results of survodutide. Now we will talk about liver, which seems to be one of its niches in terms of hopefully clinical indications in the future. And this is a really important study of about 300 people that were randomized to placebo versus 2.4, 4.8, and 6 milligrams of survodutide. 6 milligrams is now the highest dose that is being used in clinical trials. And these were all people that had biopsy-proven MASH with fibrosis, with a steatohepatitis score of over 4 and a fibrosis score of F1 to F3 with a BMI over 25. The trial lasted for 48 weeks, again, making it as comparable with other molecules in the field. Here, what you're going to see are the key results. These were, pay attention to this title there, people who had MASH and fibrosis F1 to F3. And these are the proportion of people who had improvements in MASH with no worsening of fibrosis over 48 weeks. In people that had paired biopsy results, So N equals 53 in the groups, smaller number than this one. I'll come to that in a sec. You're seeing that about 60 to 80% of people had this improvement in mass with no worsening of fibrosis. If you look at all of the data, independently of whether the biopsies were paired or not, you're seeing similar trends with a maximum effect size of 60%. So these are really good numbers. What you will notice on this slide is that there is no clear dose response curve. So even though people in the 6 milligram dose lost more weight than those in the 4.8 and those in the 2.4 milligrams, this did not translate to higher improvements in MASH. And why might that be? Well, it might be because of the direct effects of glucagon on steatohepatitis, which we said is independent of weight loss. So it's not the typical dose response curve that we have seen in other molecules that do not use glucagon as part of the mode of action. And if we pay attention to this slide, this is a slightly different representation of the results, with about 65% of people who had more advanced fibrosis, F2 and F3, achieving a reversal of fibrosis without worsening of mass at 48 weeks. 60%, again, a very meaningful clinical outcome. And similar results in different ways of analyzing the data. This is an important slide, which I will explain. What they've tried to do statistically here is try to understand how much of the improvements in mass resolution, mass improvement, and improvement in fibrosis were due to natural direct effect, i.e. of glucagon, versus natural indirect effect, i.e. Weight loss. And you'll see here that in terms of mass, in terms of all of these parameters, the direct effects of glucagon activation seem to be superior to the effects of weight loss if you were to compare them. But if you were to combine them, you see a very large effect size, and that's the beauty of combining weight loss dependent and independent effects of these gut hormones. In terms of timelines, you see what you would expect looking at liver transaminases, so ALT, a very nice reduction with stabilizers over the course of 48 weeks. The same with AST, and reflects a reversal of the pathology as we would expect. Let's move on to what we are expecting to be published this year, and that is what we are so excited, is because there will be a readout of at least 2 of these studies this year. My BI colleague will correct me as to when the last phase 3 will read out, the CVOT. So let's go through them one by one. Synchronize 1. This is a phase 3 study of 700 people in which survodutide has been used for the treatment of obesity without type 2 diabetes. Synchronize 2 is exactly the same type of study, but here these are people with overweight, obesity, and type 2 diabetes. And finally, the trial that I had also the privilege of being a site for, 5,000 people, in which the safety, not the superiority, but the non-inferiority of survodutide is being tested. Larger study, 34 countries. So we're expecting the readouts of the first 2, certainly this year, and the cardiovascular outcome as well, either this year or next year. And these are critical, pivotal studies before the decision is made about licensing this medication around the world for the treatment of these indications. Of course, in addition to that, there is a liver-specific program, phase 3 program. One of them is called Liverage, of 1,800 people. Again, typical randomized controlled clinical trial, double-blinded, placebo-controlled. And here in people that have got biopsy-proven MASH with fibrosis of F2 and F3, and also liver cirrhosis, same design, but the indication here, the eligibility criteria, are MASH with compensated cirrhosis, so F4, a step further than liver here. It will take a while before these trials read out, 2029, 2031, possibly a little bit sooner. But this may make survodutide, fingers crossed, potentially the second GLP-1 based molecule that may have an indication for liver disease in the future. We hope that this happens, it is safe and effective, and will be useful for our patients. You'll see from this map that a number of countries around the world are taking part in these trials with more than 10,000 participants across the world. So I'm going to finish off by summarizing and saying novel mechanism of action because of the glucagon activation through the same molecule, very meaningful reductions in HbA1c even in the short period of time, meaningful body weight reductions at week 46, and more importantly, when it comes to end organ damage, improvement in MASH without worsening fibrosis, which seems to be dose independent. And I'm going to finish off here. Thank you very much for listening. I will now pass you back to our chairperson.
Thank you very much, Dr. Miraz, for this excellent presentation and also for enlightening us of this new molecules and all the clinical trial is taking part around this subject. So we will go to the Q&A session, and I can see there are some questions into the chat box. So just let me just access this. And 1 second. So I'm just going to the chat. So I just start first of all with Dr. Khadija. What is the, this is from Dr. Ahmed Turkoman, and what is the relationship between the chronic inflammation and weight loss? How does the inflammation affect the weight loss?
That's a very good question. And, you know, we know that obesity itself is associated with the chronic inflammation through, you know, a lot of different pathways. So weight reduction, we think, can help with a lot of these clinical outcomes by reducing the inflammation, just as we find with the heart. You know, when you reduce you reduce the fat that is deposited around the organs, and therefore reduce the chronic inflammation, because the soil, the common soil, is the inflammation that is occurring in these excess adipocytes. So if you reduce the burden of the obesity, we also, you know, reduce the amount of inflammation. That is the theory, of course, and we don't do sort of adipocyte biopsies and things like that. We have surrogate markers that tell us that, right? We don't have specific biopsy things that we've done in sort of clinical practice, so we have to rely on the biochemical markers for that relationship.
Thank you, Dr. Khadija. Any input from you, Dr. Miraz?
No, I completely agree. I think we can move on to the next question. Thank you.
Okay. I think this question to you, Dr. Miraz, is there any difference in the hypoglycemia rate between those on survodutide compared with the GLP? I mean, theoretically, can glucagon lead to less hypoglycemia?
Well, again, remember that we have one trial, the phase 2 study that I have just presented, and the good news is that it did include a head-to-head comparison with semaglutide, again for a short period of time, but there was no difference in terms of hypoglycemia episodes between survodutide doses and that of semaglutide. Again, it all depends on what kind of patients are recruited in these studies. I think what we're going to learn from the phase 3 studies is what happens to people, for example, that are on insulin or sulfonylureas that are more prone to hypoglycemia. And the question is, does glucagon rescue some of that? Again, very exciting to see the result of the phase 3s, but at the moment, no hint that there is a difference.
Right. Thank you very much for the input. This is a question from Dr. Ahmed Hassoun, and I think it's again to you, Dr. Miras. Muscle effect of survodutide, more volume and function? Is it volume and function together?
Volume in terms of what?
This is what I think, Dr. Hassoun, if you just make your question clear. Meanwhile, I'll just, move on. Dr. Khadija, you mentioned many comorbidities related to the obesity, and here one question from the audience: what are the major side effects associated with obesity in the long run?
Oh, yeah. So, we have that very beautiful slide that shows from head to toe. You have, complications, long-term complications, related to both metabolic, mental health, mechanical, so, osteoarthritis and things like that. The 5 sort of common ones that keep us busy always is, of course, diabetes, metabolic syndrome with hypertension, cardiovascular disease, kidney disease. So these are the things that are most common. But, liver disease, as we're now highlighting, is not a silent bystander. People with obesity are more prone to infections, as we found out during COVID. They are the ones who succumbed more to the infection and required more intensive therapies. Reproductive health, women with obesity, infertility, then there's, of course, the malignancies as well, the higher risk for malignancies in people with obesity. So there's a lot of complications. There are over 200 complications, if I remember correctly, that are associated with obesity. But of course, in clinical practice, we kind of tend to see these clusters of metabolic problems that keep us more busy.
Thank you, Khadija. Dr. Miras, any data about kidney outcome or a glucagon agonist? And this question from Dr. Mohammed Qasim.
Not yet, not yet. However, from the phase 3 study, the synchronized CVOT study, there will be patients who have got kidney disease. I know because I included some of them myself in the people that I recruited. And even though this is not going to be a primary outcome, it's going to be a secondary outcome. So really eager to find out what happens to CKD. Independently of whether it is related to diabetes or not. We have seen good results of all the other available GLP-1 based medications. So let's see what we get, and we will find out that answer within the next 12 months, I hope. But we suspect it's going to be a positive result.
Thank you. This question is for both of you, so anyone will take it. Are single pathway therapies becoming outdated in the management of obesity and MASH, given the rise of multiple pathway drug that we have currently?
I'll get to answer that, Dr. Khadija, and then please feel free to contribute. And I'm saying, well, I thought that this would be the case, that the single molecules were, first or second generation, and that's about it. And now we're all moving to double and triple agonists. But what we are learning from other phase 2 studies in the field is that might not necessarily be true. An example is the use of amylin as another target for pharmacological development. And now we're seeing drugs that stimulate just the amylin receptor on its own without GLP-1 activation, causing a very good effect size in terms of obesity and associated comorbidities. So I don't think we are there yet. I don't think we can say that yet. It seems that the way that pharmacology is manipulated makes a more of a difference as to whether we're activating 1 or 2 or 3 pathways. So the number of pathways seems to be less important than the pharmacology that we are using to activate the specific pathways.
Sure. Thank you.
I
Yes,
think I
Khadija.
would tend to agree. I would agree with that, and maybe just add that obesity is indeed a complex disease, and we're only beginning to understand some of the nuances around the pathophysiology, and what we're able to harness and then study, I think is quite limited. But the future looks bright, and the more sort of receptors and targets we look into, finally we might be able to hit bull's eye and get to the bottom of tackling this disease. I mean, it's a bit like type 2 diabetes, where we have also multiple agents, because there are so many different pathways that we need to look into, and we haven't yet got to having either the genetic profile of patients to say which patient is going to respond to what. That's another component as well. So we do give these treatments sort of based on the physical phenotype, but we don't know what the genetic milieu is like to guide us, and maybe that is what we need to look for in the future.
Sure. Thank you for both of your input. The other question is, how does glucagon receptor activation avoid excessive hyperglycemia in treated patients? Dr. Miras?
Well, I think there are 2 points to this answer. The first one is that you saw earlier on that the activation of the glucagon receptor with survodutide is very specific. It is 8 times less than that of GLP-1, yes? So it is balanced for exactly that reason, to avoid hyperglycemia, but also other side effects. So the design of the molecule avoids that issue. And the second thing that avoids this issue is the fact that the GLP-1 effect of insulin secretion and insulin sensitivity because of weight loss counteracts any effects the glucagon part of the molecule may have on increasing glucose. So because of the design and because of the physiology, we are not seeing severe hyperglycemia because of glucagon activation.
Right. Thank you very much. Back to Dr. Ahmed Hassoun question. He just type it in a different way, just to say, if the drug effect negative on the volume, how about the function? And also, BMR was measured or not?
Okay, when we say volume, I'm just guessing that we're referring to adipose tissue volume. And the answer is, if that is the question, then yes, we're seeing a reduction in the adipose tissue mass because of weight loss. We're also seeing direct effect of glucagon on adipose tissue, which causes lipolysis, which is a positive thing, and it also contributes to weight loss. But further beyond that, in terms of what happens in adipose tissue physiology, I don't think we know. And what was the last bit of the question?
And if there is any effect on the basal metabolic rate as well?
Yeah, so basal metabolic rate is being measured in separate studies of survodutide to find out what the effects on energy expenditure are. We know from acute infusions of the hormone glucagon that there are increases in energy expenditure. And we are hoping that that will also translate to humans that are being treated with this analog, but we don't have results yet. Studies are taking place at the moment that are measuring basal metabolic rate in addition to other parts of energy expenditure in humans.
Thank you. Khadija, how do you approach a patient who prefer an oral therapy, but would clinically benefit from more of injectable agent?
Oh yeah, that happens all the time in practice, right? You suggest something, they said, oh, isn't there an oral formulation? And I think it's really important to take the patient's preference because it means that they're more likely to then adhere to the drug. You could prescribe the injectable one, but if the patient has not yet, doesn't have the buy-in, then they're not going to take it, and it's going to be the most expensive medication, I think, is the one that is not taken. So it is just a question of education and looking into reasons as to why they're so averse to having sort of injectable therapies, and then working around that. With most time, we are able to convince them to take the injectable therapies. But yeah, there are some hardcore people who would absolutely say no, and then you just have to go with it.
Sure. And I just want to follow it with another question, Khadija.
Yeah.
Are there specific patient, let us say, hint that you found most predictive for long-term adherence to the obesity medication from your clinical practice?
So usually the ones who have that dramatic response right from the beginning, they're the ones who tend to stay on the drug for longer. The ones, of course, who have not experienced any sort of side effects. And the ones who are more sort of engaged in terms of their lifestyle modifications as well. Those patients who've got good family and social support are the ones I found that are much more adherent and tend to stay on the therapy for longer periods.
Okay, there's an interesting long question, which I'll address to both of you. Obesity is unfortunately skyrocketing, and it is according to the attendee, I personally feel that hitting obesity with a multiple target rather than only one is going to be the future. So my question with regard to the new medication as a dual target, was it studied in genetic cause of obesity? And any indication in monogenetic obesity, for example, or any specific group of obesity patients that tend to be more responsive than any other GLP agonist? Dr. Miras, very long question.
The answer is that the answer to all of this is no and no. We don't know. It has certainly not been studied in monogenic obesity. We know that. Are there any predictors that have been identified at baseline as to whether the drug is not going to work? Absolutely not. So this is work that's going to be coming out over the next number of years. Yeah. What we have just presented are the first steps towards showing that this drug is safe and effective. And after we have demonstrated that, after the phase 3 studies are out, then we can start looking at predictors. But at the moment, there are none.
Right. Thank you very much for this. Khadija, is there any correlation between a high total cholesterol and a high LDL with fatty liver?
So we know that there is a correlation, yes, and in clinical practice we try and we know that patients with dyslipidemia, with high cholesterol, with obesity may also be at risk of having a fatty liver, but whether to say that there is a bidirectional relationship, I can't say that for sure, because we do have patients with dyslipidemia who do not have metabolic dysfunction associated liver disease, and vice versa. So there is some relationship, but I would say it is all again within this sort of metabolic realm that we're not quite sure of.
Okay, and it's to both of you. Thank you, Khadija, and this is to both of our speakers. What effect on the lipid profile of this drug, specifically of the new drug?
Yeah, so I showed you a hint of what the drug might be doing. What I would take for now, and the one that is consistent, the result that is consistent to what we already know is the very large reduction in triglycerides, which is in the range of about 25 to 30%. And I would just keep it at that. What happens to HDL and LDL? We are going to get a lot more information from the phase 3 studies.
And I just want to follow it with one more question. Is there any study for those childhood obesity, Dr. Miras?
No.
I mean, those
There may well be in the future, but not now.
Yeah, right. Okay. And I know there's a question related to the insurance, but Dr. Barakat, I'm not, ignoring this, but, future when we have these drugs, we will, look into those insurance-related issues as well. The other question that I would like to ask from Khadija, you presented the prevalence. We have a high prevalence of course, of diabetes as well as also obesity in our region, and specifically in United Arab Emirates. So among patients with type 2 diabetes, muscle prevalence in the Middle East is estimated to be 71%. Given the high rate of both type 2 diabetes and obesity in UAE, how should this intersection be prioritized in a clinical pathways?
I think I would bring it back to Dr. Barakat's suggestion about the insurance. I think that's where, as patient advocates, that's where we need to start with. The policies need to change because we identify these patients and then the treatments are available, but the insurance is not covering. So I think one, the screening is essential. So we identify them. Once we've done that, let's make sure that the insurance is going to cover them, so that we're not ending up with having too many people on the liver transplant lists.
Right. Okay. And question is for you, Dr. Miras. For patients with obesity who achieve significant weight loss with pharmacotherapy, but still have residual liver fibrosis, what should be the next step? Do we need to continue with the same agent, or we add on liver target therapy, or we do just surveillance?
A very good question, and that there have been some relatively recent advances in this, which are demonstrating that fatty liver disease is not one disease, but a collection of sub-diseases. And yes, we would expect that a proportion of fatty liver disease will respond very nicely to weight loss, but there will be another subtype of fatty liver disease that will not respond to weight loss. And for that type of fatty liver disease, we need to use liver-specific therapies, as you have exactly described. Glucagon may be one of those therapies, may have a direct effect, we know has a direct effect, and therefore it may work in those people. But also all of the other medications that are being developed at the moment that have got weight loss independent effects on fatty liver can also enhance the treatment of the GLP-1 based weight loss. So if there is residual disease, like what we do with cancer, right? If we give one chemotherapy, but there is a residual cancer, we may add additional chemotherapy or immunotherapy or other therapies to remove that residual disease. And with time, we should be able to do with fatty liver disease. The issue is that here we're moving rather slowly. Fatty liver disease has not been an area which has been very busy, right? We really don't have any medications that have been licensed for fatty liver disease. It's only now that medications are being licensed, and we will start seeing a combination of them in the future.
So can I just follow this, Dr. Miras? This is a question from Dr. Bakri, because we already have the Rezdiffra, which is the resmetirom, and can it be combined with the drug you presented for the MASH, since they both work in a different pathway?
Theoretically, that is a very reasonable suggestion. We don't know because no one is doing the studies yet, or as far as I know, no one is doing the studies. But absolutely right. Different pathways, like what we do with obesity, right? We've got medication that address different pathways, and theoretically, if we combine them, we can get a more positive effect. Again, the difficulty here is having evidence for that because it's difficult at the moment to do trials that are of molecules that are being manufactured by different companies just for practical reasons. But all of this will come. In the meantime, we just need to use our judgment. We can try to, with caution, try some of these combinations in clinical practice to test whether there is any efficacy, but I just need to stress that at the moment, and probably for quite some time, we will not have results for this important question.
Thank you very much. Khadija, from practical point of view, what are the most impactful missed opportunity today for an early diagnosis and intervention?
So these patients are always lurking in our midst, but I think we miss them because we're not actively thinking about the screening, right? And we highlighted that in our recent type 2 diabetes guidelines this year during the Congress. We updated the guidelines and we made a specific mention about the algorithm for screening patients with type 2 diabetes with obesity, metabolic syndrome, to look for the liver issues as well. And I think maybe the other thing is probably thinking about moving the CKM to CKLM, adding that one more letter in order to increase the awareness that the liver is not a silent bystander. And we need to be looking for these patients because only when you identify them is when you will then think about offering them the correct therapy. So if it's somebody comes in and they have just, obesity, we've said, please look for the other complications, because then it then puts them in a different pathway. If they do have that, then they would warrant to have the specific treatment to try and reduce MASH.
Sure.
I'll add a couple of points, if that's okay, on what Dr. Khadija has said, which are that at least when it comes to fatty liver disease, the uncertainty of who to screen, with what, and how is it going to change management has confused us for a number of years, right? So that's why we may not have been as proactive as we should have been. And secondly, the need for a liver biopsy is a real challenge, is a real barrier in moving forward in terms of treatment, okay? So what I'm hoping will happen is that in years to come, we will be reducing the number of liver biopsies that we need in order to treat this condition. We should be relying, and there are moves towards that, we should be relying on non-invasive testing, for example, MRI, elastography, etc. And that will really make our lives easier when it comes to diagnosis. So I don't think that we have necessarily been forgetting about fatty liver disease. I think we just didn't really know who to test with what and how often in order to reach a diagnosis. Hopefully I hope that will be streamlined, and the FDA are taking steps towards that direction.
Sure. Thank you very much for this input. One more question for you, Dr. Miras. Would glucagon receptor activation could cause amino acid catabolism and muscle loss? And this question also had been asked from the audience, Dr. Hassoun, whether there's effect on the muscle loss. The evidence suggests that amino acid reduction does not directly correlate with the muscle loss. But how confident are you that the clinical trial you had presented, can monitor what will happen in the future with the outcome of these trial, soon in many of the conference like the ADA, EST, studies.
Yeah, no, that's the amino acid, yes, has been observed, and we are already having some level of uncertainty as to the muscle mass that's lost with weight loss, independently of what the modality is, with semaglutide, tirzepatide, bariatric surgery, okay? Now, the good news and I'm leaving glucagon aside just for 1 second. The good news is that even though we are observing some muscle mass loss, function gets better, yeah, in all of those studies. So we cannot really meet the diagnostic criteria of sarcopenia for these patients because their function gets better. So I'm hoping that in the next 6 and 12 months, we will see data from the existing molecules in clinical practice to hopefully reassure us that the muscle mass loss may not be such a big thing as we currently think that it might. The effects of glucagon on amino acids adds an additional level of complexity. Yeah, I have a feeling, we will find out with the studies that are being done, but I have a feeling that even if, say, there is an effect of glucagon on amino acids, that what we're going to see is that overall, because of the numerous benefits that the patient is benefiting from in terms of weight loss and functionality, I expect that this will counteract any theoretical issues glucagon may cause to amino acid metabolism. So I expect that the weight loss, the removal of fat from muscle, may make the muscle look smaller, but it will be healthier muscle and more functional muscle. But very good question, something to watch out for. Keep an open mind.
Thank you very much for this input. Khadija, again, utilizing the resources we've got in our institute here and different public or private sector within the United Arab Emirates. And, considering that you had already mentioned that MASH project to become a leading indication for maybe liver transplant, how should healthcare system prioritize the non-invasive fibrosis screening like the FEB4, the VCTE, and that you had mentioned in primary care setting, managing patients with obesity and metabolic syndrome, as we know that maybe there are limited center who maybe do this?
Right. So that's a good question. And I think, as Dr. Miras had mentioned, that this diagnostic ambiguity that we had in the past is becoming a little bit easier now. So the FIB score is a very simple tool. It's non-invasive. It's simply you have your patient's age, their AST, ALT, and the platelet count. And that is always available because if your patient is, whether in primary or tertiary care, you're going to do the liver function test and you're going to do a CBC, you will have the platelet count, and that can be calculated automatically, right? And then you have the algorithm and just look at the cutoff points. And there is a cutoff point for referring on the patient to specialist services. So that should help, so there's now, it shouldn't be a barrier now for primary health care physicians to be looking for liver-related disorders in their patients, and then referring them on based on that score. And then the specialist services will determine whether then the patient needs to have these further diagnostic workup tests. Is it just related to obesity, or are there other liver-related disorders that need to be looked into? So I think having that as kind of like a screening will make life a lot easier, for primary care physicians and for people who are looking after obesity, I would say.
Sure. Thank you, Khadija. One more question from the audience. Dr. Miras, you already had shared with us in your study that the survodutide deliver 18% weight loss at 46 weeks. And, the curves tend to, go downward, and it suggests the longer the treatment, then the better the outcome. So what will happen after the 46 week?
Well, we will find out in the next few months because we're going to get the results of the 72-week studies. This is a start. Yes, this is a first step. You will remember from semaglutide, as an example, we first had 1 year data, 2 years, and then 4 years. Yeah, they came one after the other. Sarvodutide is still a very young molecule. We're going to get the 72-week data in the next few months, and then the studies will be extended, hopefully, if everything goes in the right direction, and we will be able to comment on the efficacy and safety of these drugs over a number of years. So these are certainly the type of studies that these companies are now almost routinely conducting and will continue to do so. So step by step.
Thank you. As you said, soon in summer, we will be hearing all of these outcome results. Khadija, what single message should our UAE healthcare provider take home to stop MASH being missed in obesity care?
I think the simple thing is look for it. Screen. Yeah, that would be my simple message, that let's start screening.
Right. And Dr. Miras, I mean, you think which population will, benefit from this?
Well, yeah, good question. I think obviously the liver disease population is a niche, right, area that we are again expecting this drug to be indicated for. It will take some time, of course. So we're hoping that will be a subpopulation of people with obesity that stand to benefit from the direct and indirect effects of the molecule. With regards to obesity in general, which other subpopulations stand to benefit, we don't know. Because as we've said already, we have got no predictors of success depending on what the molecule is and what the background of the patient is. So I expect that, again, it will be one of those trial type of clinical practices in which if someone hasn't responded to a GLP-1 based treatment on its own, we may add the glucagon component to it and see if they respond. If someone hasn't responded to a GLP-1 and GIP, we may move them to glucagon and the other way around. So that type of testing the efficacy depending on the response to other treatments. And for the moment, this is going to be a little bit blind. Yeah, we'll be a little bit in the dark, trying one, seeing if it works, as we do for many other things in medicine, right? In hypertension, we try an S inhibitor, see the effect, and then we add a beta blocker or we change the beta blocker. And we are now getting into the sphere of being able to do this with obesity pharmacotherapy. Don't forget, I'm sure you will remember that for 10 years, we only had orlistat. Yeah. So this is a really big jump, a really big leap forward.
Right. So with this, I know that there's, very interesting topic, and there are, many questions in the Q&A I'm seeing in the chat, and, it's glad to say there's, still now there's 422 on the platform who's watching this, plus also on the YouTube channel. So with this, I would like to thank our both speaker for this excellent, presentation. And Dr. Miras, thank you for having you with us to enlighten us about all the, excitement and advances in this, as you said, the niche area. And Dr. Khadija, also, thank you very much also for putting the platform for this discussion. And I'm sure that we will going, as this is a new area for all of us, I'm sure, there's more and more of excitement will come as we go on. It's also, also thankful to our great audience for this, interactive session. I myself also thoroughly enjoy it. So thank you very much. And I apologize for those who I was not able to take their question. But definitely we will be addressing it at a different forum. With this, I would like to thank you all for attending this webinar. And as I mentioned earlier, that the CME will be available 4 weeks after the webinar, after you, of course, answer the survey. Please make sure, because this is also will improve the activity that we deliver through the EDS. And that will be, you will receive it on the register email. You can still watch this interesting webinar on our different channel, and it's already, mentioned here. So please feel free to log. And also watch for our future activities. On Monday, we have also another exciting webinar. So myself and Dr. Khadija will be in that, and other colleagues. So please, we encourage you also to attend. With this, I would like, to wish you all a great weekend, and stay safe. Thank you very much. Bye-bye.
Thank you.
Thank you.